to say that these are the two people behind the idea, and we've done a bit of introduction, but just to say that this company has been funded by the co-founders, and we have not received any funding from anybody. So like people say that it takes a man to invent, but it takes a team to innovate. So we have a team of people supporting us with these innovative ideas. And we also have a scientific advisory group that gives us some technical support in terms of science within the HIV disease area. I also want to say that the panelists have no financial interest or relationship with Bohemia SmartHIV. So what they are doing today is pro bono. So there's no financial incentive for them participating in the session. Just as a bit of introduction, I'm sure you guys know this data more than I do. Currently, we have about 38 million people living with HIV. And we've seen that over the years, this number has actually stabilized as a result of all the different interventions that we have currently. And even if there's a vaccine today, it shows that we still have about this much people that we need to cater for, and with all the attending challenges. And that was what gave us the idea of how do we come up with a solution that will be able to support not only people living with HIV, but also all the practitioners that have boots on the ground at the forefront of the fight against the disease. So before we started, we thought, how come that the uptake of digital innovation within the HIV is a bit limited, and we wanted to see whether there's a need to develop anything, any digital innovation within the HIV sector. So we did a survey before the development started, and it turns out that actually there's a huge need, there's a huge gap in terms of digital innovation within HIV disease management. Everybody we surveyed, 100%, either patients or clinicians or service managers, everyone has one need or the other that needs to be met. And that was something very interesting for us. And we also see that a lot of people believe that a digital innovation in this field is actually a need, and that they will use it if it were to be available. Note that at that point in time, it was just a concept that we had. The solution was not available, but we still managed to find 93% of people saying that they will use the solution if it were to be available. And about 3/4 says that they are very positive towards a digital innovation, and also they would recommend it. So we were a bit excited, and we decided to go ahead with the development. And what's the solution? Based on this survey, we were able to identify certain stakeholders that are really at the forefront of the fight against the disease. We know that there are service managers who are trying to balance resources to be able to support services to HIV patients. We have the clinicians who have a need to be able to come up with the optimal ART for patients. And we know that patients are growing older, and they are open to other comorbidities, which makes their cases a bit more challenging. So they need a tool that will help them to personalize the treatment to patients. And we also identified the clinical researchers and trialists who are running clinical studies, testing new innovative medicine, all with the focus on the patient. And the patients also have a lot of challenges that they are dealing with that needs to be solved. So we decided to bring all these stakeholders onto the same collaborative platform with the focus on the patient, so that they can talk to one another, they can share data among themselves, so that they can provide optimal services and optimal treatment to the patient. So these are the tools that we've come up with. We've got the SmartHIV Clinician, which as the name suggests, this is for clinician, and it supports them to be able to provide the best possible treatment for patients, even with all the attending challenges, comorbidities, and this is a tool that is different from every other tool. This tool is not doing any modeling. We are just crawling all available evidence and presenting it in an easy to use platform for clinicians to be able to manage patients. And we will be seeing a demo of this in due course. And we have the BSmartChat app. This is an app that supports the HIV patients in the day-to-day management of the disease. It supports them not only clinically, but also emotionally. And we will also see a demonstration of that in due course. The Smart HIV Manager supports not only managers, but also policymakers in the planning of services and how they would be able to see the impact of different possible policy scenarios, the impact it will have. And you can use this tool to actually do forecasts over 3, 5, 10 years. So Aaron will also be demonstrating this in the course of the session. I will move first to the Smart HIV trial list, which I mentioned before. We also want to be able to support clinical researchers to be able to test innovative products in patient population. And we know that there's limited participation in clinical trials, especially in the areas where HIV burden is really high. For instance, there is limited participation in certain population groups, especially in Africa. And we thought that if we have patients consenting through the app to participate in clinical trials, we can then link them to possible trials and they can be enrolled in the clinical trials. This also offers another advantage in the sense that in some countries, there's only a handful of ARTs that are available. However, if patients are enrolled in clinical trials, they might actually have access to medicine and innovative therapy. We then put all this together in what we call an HIV Smart List, whereby we integrate all these onto one platform, also with an existing system. We know that people are using different EMR softwares, people are using different systems. And with this solution, we're not saying you do away with those systems, but we can actually integrate your system into the solution, and we build a visualization platform where you can do real-time analytics. So that is in general what the solution is all about. I'm going to pause a bit in case there's any question in the chat.
No, Sean, I think you can proceed. There's no questions so far. Just carry on.
All right, great, thanks. So what I wanted to say is, how does our Smart HIV solution fit within the different stakeholders ecosystem? And the first one that I'm showing here is digital ecosystem stakeholder. And we can see that based on what I've said so far, our app fits within the citizen and patient, because within the app, we've got a profile for patients, we've got a profile for clinician, and we've got a profile for a body. A body could be a family member, could be a friend, could be a parent. So we have come up with a solution that fits within the layer of the citizen and patient. And all around here, providers, policymakers, administrators, these are some of the stakeholders that fit within the Smart HIV Manager. So they can use this tool for planning of services, for testing policy scenarios. And we've got the Smart HIV Clinician, which can be used by providers and allied private entities or even healthcare professionals. So we've tried to cover a lot of the needs of these stakeholders, and we can collect and transform the quality data that is coming into this from all these stakeholders into clinical and operational insights that would build evidence to improve patient outcome. And this is actually where we think that our Smart HIV solution fits perfectly. And leaving the digital ecosystem, if we want to look at some other socio-ecological framework, especially within the people living with HIV, these are some of the factors that influence the uptake of of services and treatment. And we can see that all these are also around things that are that are at institutional level, at policy level. There are things that are based on the client's expectation and whether the acceptability, as well as community-based factors and healthcare factors. And our solution actually addresses everything, if not all, most of all these things, which actually will improve the acceptability and leads to increased access. When we start to do the demonstration, you would appreciate and see how our solution actually helps to mitigate some of these challenges from a client perspective. And if we look at some of the barriers, and facilitators to retaining and re-engaging HIV clients in care, and also stakeholder perceptions, we realize that these are all, similar to the ecosystem that I showed earlier. They're either at the individual level, family or community level, and then the structural or institutional level, the same thing. So we can see that it doesn't matter how these ecological models are, are defined. We can see that it's all about stakeholders management, but with the focus on the individual, which is the patient here. And we can see that, as we will demonstrate, that our solution actually caters for all the needs of all these stakeholders. And so we are right there at the center, and we make sure that all this another feature that we have within the app, which is we also build in a quality improvement strategy, such that the system can learn and relearn over time and come up with a quality improvement checklist for organizations or even community level. So what I wanted to say, this is about my last slide. We've got all this, this is the HIV pathway actually, and we see that our app is actually in the middle of the client's pathway from diagnosis up until community. So from the time they enter into the hospital until they go into the community, the app tends to support them all through. And in fact, they really don't need to come to the hospital for things like pill refill or just to get checked. They can connect with their clinician in real time. They can connect with their family support or community support in real time without having to go to hospital. They can also have their pills sent to a nearby community pharmacy for their pills to be picked up. And around that are the other solutions that help with the management of disease, management of the services, and also some kind of an audit platform that can help to see what is going on with the client, how is the services at the client level performing, and also we have the SmartHIV trial list, which can actually connect our clients to clinical trials to have access to medicine and innovative therapy. So the app is currently available for download. There are people who are already using it. We've got amazing feedback about the app, and it's out there, and we're just waiting for some kind of visibility such that this can be made globally available everywhere it's needed. So I think that's the last slide that I've got. I don't know if there are any questions.
Thank you so much, Shola, for a concise but really rich introduction. There might not be a question now, but I'm pretty sure actually the many in attendance would certainly get more when they get to see the demonstration. So without waiting further, I think I'm going to allow Erin to step in and demonstrate those so wonderful tools you just described. Erin, over to you.
Thank you very much, Andre. Well, there's a lot to take in actually in the demonstration. I know Shola's just done a brilliant summary of SmartHIV solution. So the demonstration is in 2 stages. We're going to start with the BSmartChart app first, okay, because clearly the evidence from systematic reviews shows that digital solutions like BSmartChart app interventions has the potential to support patient self-management, treatment adherence, reduce stigma and discrimination, improve patient outcomes, and so on. So, and all of this is really to empower people living with HIV and can take control of their disease. So that's the first kind of bit of the demo. The second part is we're going to have a look at all the other components that Shola just summarized, the SmartHIV clinician, for instance, to support clinicians, the SmartHIV manager, and so on and so forth. So that's the kind of the plan. I'm going to start sharing my screen using my mobile phone. Hopefully this should work. Can you all see my screen, the mobile screen?
Yes.
Is it visible? Okay, brilliant. Just quickly set this up. Okay, right. Let's get started with this. Now, as Shola just mentioned, the app is available to download on Play Store and App Store. Okay. What we have is we've got 3 profiles here. We've got the patient profile, clinician profile, and I'm a buddy. So there is this kind of a 2-way communication or 3-way communication between a patient and a healthcare professional. I'm a clinician, which I'll demonstrate how that works, and also a communication between the patient and the buddy. So the buddy could be a friend, could be a colleague, a family member, who could then provide the support throughout their journey, so where they can have an honest conversation about their disease, monitor their friends and colleagues' disease over time. So we'll have a look at that as well. So we've got these 3 profiles. Now, a patient could create an account either using their phone number or email. So I'm going to start assuming that you've created an account, and the first thing is you log in. So I'm just going to just log in with my username created using my email. Password. And once you've logged in, you can very easily set up your PIN number so that it's dedicated for you, for the patient, and nobody can have access to it. So it kind of all starts with completing my survey. So there's about 15 categories of questions here, where it's compulsory for all users to complete my survey. Now, where you're not able to answer a question, for instance, whether if it's got to do with your metabolic syndrome or cardiovascular related questions, we would strongly recommend users to seek support from their healthcare professionals. So they can always come back, answer those questions, and carry on. So because in the first instance, all the questions are compulsory, but all subsequent survey completions, users could skip, for instance, demographic section, because it doesn't change that often. They don't have to answer these questions again. Or vaccination related question. What happens is these categories are then just removed from the set of questions. Okay, so that's the first thing, is to be able to complete my survey. Once my survey is completed, you can come to your main dashboard, okay, where you've got things like your medication reminders. So you can set your HIV medication, and so that it kind of reminds you 15 minutes or thereabouts before you take your medication. So here we are. If I can just show this as an example. So let's say this is the medication I'm taking. So Steva, I've set this up. And I can also set the number of pills left over. So it remind me when I have 15 pills left and so on. But we've added a a feature we thought which is very important is the drug-drug interaction. So, you know, I could be taking an illicit drug, for instance, cannabis, and you know, I want to find out whether if it interacts with my HIV medication. So we've got this color coding, which is, say, you know, the red in this case is highly likely. If it's yellow, it's likely, or it could be, if it's green, there's none. So I'm a patient who's, you know, could be using an illicit drug. Cannabis is highly likely it interacts with my HIV medication, Sastiva. You know, something simple as garlic, for instance, that I just want to show over here. It's interacting with this particular medication. So that's just, you know, an additional level of information provided. I have a type 2 diabetes and I take metformin as well, and that particular medication is not interacting at all. So it's an additional level of information. Just on the note of this drug-drug interaction, a couple of weeks ago, we had a user who said that he went to a hospital for a non-HIV medication, and the hospital where he had received treatment for his non-HIV medication was different to the hospital where he received his HIV treatment, HIV medication. So because between the two hospitals, the information data are not shared because they have different electronic medical record system, the clinician had no idea that this, you know, this patient's HIV status. So obviously the patient couldn't disclose his status due to stigma and discrimination here, or possibility of discrimination. So what he said is he used the app to see if his HIV medication interacted with the medication prescribed to treat his non-HIV medication. So that's where he said that he found it really, really useful. Now, obviously, the purpose of the drug-and-drug interaction is really to support people living with HIV with information. And, you know, we would strongly recommend patients to seek advice from their healthcare professional. But it's an additional level of information provided through the app. So that's the medication side. There's also, once you complete your survey, there's the adherence. So there's a bunch of questions related, self-reported adherence related questions, and according to what the users provided, it's scored as 52 out of 120. So it's good, it's around 43%. But the detail is in the report section in terms of where it kind of lays out what are the causes of adherence. So that this is just a high level information. There's also the suppression part, where we provide some facts about what is your expected overall suppression for using this particular HIV medication, Sastiva, and in order to meet that target of overall suppression of 79%, the patient needs to adhere 92% of the time, and if they don't, there's a warning at the bottom. So there is some information related to suppression for that particular medication the patient is on. We also provide some risk calculations. We know there are, comorbidities associated with HIV. Particularly, for instance, we start off with cardiovascular risk. So, based on the information provided through my survey, the risk of CVD, cardiovascular risk, is around 1.59%. So that's categorized as moderate, and what they should be aiming for is less than 1%. So, and then we give some health advice at the bottom, in order to make sure they reach the less than 1%, 30-minute exercise per day, healthy diet, stop smoking, because the patient or the user has indicated that they are a smoker here. There's also the metabolic syndrome risk, particularly diabetes, for instance. That's known to be quite a high risk amongst people living with HIV. And so we use two approaches: the International Diabetes Foundation and the National Cholesterol Education Program. Based on the information provided, this particular patient has no risk, and we provide some causes of metabolic syndrome at the bottom there. So and there are some other risk calculations that we're implementing at the moment. So the next part is alert to clinician. Now, there's two ways that a patient could interact or communicate with their clinician. One of them is the clinician connection, which I'm going to demonstrate later on. and another is through a web-based dashboard. So assuming your healthcare professional, your clinician, they haven't downloaded the app and they have no access to the app, but they can be alerted via using an email or a phone number. So I could basically say, state the email address for my clinician. Let's say this is my clinician's email. And if I can just tap on send alert, and alert successful. So clinician was alerted successfully. Now what will happen is the clinician will now receive the email. Okay, so hopefully if I scroll down, just for demonstration, here we are, that's the email. So that's the email received by the clinician. Okay, there's some text here. And what they'll have to do is just tap on view report. And so this is now coming from our web-based dashboard, which I'm going to show later on. So what you have is the usual, the patient, some very high-level patient information here. Okay. And their HIV regimen, some of the non-HIV regimens, for instance, the illicit drug cannabis is mentioned here, metformin is mentioned here, the type 2 diabetes medication, and something around the adherence, for instance, 43%. So that needs to be discussed with the healthcare professional. This is well below the recommended level of 92%. And then there is some physical symptoms or some side effects, for instance, that the patient is experiencing. What you see is a longitudinal graph here. So in this case, this particular patient have been using the app since July, and they've completed the result, the survey periodically, almost once a month. And you can see how they're, for instance, night sweat, for instance, they started off with some, but then again, back in July again, it's a great deal. They've improved over time, the next month and so on. So the healthcare professional can keep a track and monitor in terms of how the patient is doing. I can scroll down. So we've got some key outputs, key metrics with extracted from my survey. So most of the time, there's no weight loss, but in December, they're experiencing some weight loss. Their general health seems to be okay, in November, in September, but in December, they've mentioned that it's fair. Health compared to 1 year ago is very poor, so something the healthcare professional may need to look at. Happiness about life, it's poor. Again, a discussion that needs to be had with their healthcare professional. Their viral load and CD4 count, well, in 3 occasions it was suppressed and then unsuppressed. Memory loss, difficulty planning, and so on. So these are some of the metrics that we show through the dashboard. But as I said earlier on, the detail is in fact in the app when they establish the connection between the patient and the clinician. So that's the alert to clinician, and very high level health and well-being that we present over here. Something about what we present over here in the health and well-being is the latest survey completion. So according to the latest update, their general health and happiness seems to be quite poor. They are depressed. They have loss of interest in life. So things that needs to be looked at, as I mentioned earlier on. In addition to medication, they can set their appointment reminders, whether it's a routine checkup or a viral load test and so on. We also have daily motivational quotes. I mean, it offers the inspiration that's needed to start a day. I mean, often it has the power to motivate and encourage, especially when you feel unhappy or lack motivation. And during the workshops that we've had two in Nigeria and one in Kenya with about 35 people living with HIV, they absolutely love this feature. I mean, we knew this could potentially have some impact, but not as high as this. This seems to be working quite nicely in terms of the daily motivational quotes provided at 9 a.m. each day. And also the your information needs. So this is where there's about 15 or 16 categories of information that we provide. So all of these are credible information. This could be, journal articles. That's very easy to understand. All the latest developments around HIV, the medication, around this could be education, this could be around legal status, this could be around HIV transmission, and so on. So all of these information are provided over here, where they can tap on whatever they're interested. Say disclosure of HIV status. You tap on it, and it just takes you to the article, the magazine, or whatever for them to read. So there is that section as provided. If I can go back. So that's the main dashboard. But the detail, so there's few other features here. If we want to deep dive into my reports, the detail, it's all in the report section. So I can say, look, because we recommend users to complete the survey periodically, they can have a look at their, they can monitor their condition over time. So I want to monitor starting from July, so going back almost the last 6 months, okay? And here I have my adherence, for instance. My latest adherence score is 43%. I mean, I've started off quite well back in July. It's good. I've improved sometime again in mid-July, but over time, there's a bit of a deterioration, okay? But now I'm at fair. So this is my adherence with my medication is fluctuating. But what is it that's holding me back? So these are all the issues: adhering to treatment plan due to side effects, integrating treatment into daily routine, sticking to treatment schedule, and so on. So these are all the issues that the patient is experiencing in terms of not adhering to medication, something to be discussed with the healthcare professional. So that's the adherence side. I've shown the risk calculator, cognitive problems. So there's more in detail, memory loss. So again, it seems to be doing quite good. Difficulty planning activities, again, is fluctuating, but okay, in July, they were much better, but there's something going on for the past couple of months, few months. Difficulty planning attention again. Okay, so there's the physical symptoms, night sweat, the headaches, the dizziness. So if I can just scroll. So here we are. It's this particular patient has a great deal of is experiencing headaches, dizziness, muscle pain, and so on. So there's quite a fair number of physical symptoms we present in the report section. The viral load and CD4 count, so it's fluctuating. Quality of life that was presented earlier on. So that's something that needs to be looked at, because clearly this patient is feeling fairly depressed, unhappy for whatever reason. So that's the reporting side. Now, all of this information is, and more, is presented or provided in the clinician section once they establish connection. So I'm going to get to that later on. They can disclose their status. For instance, let's say I want to disclose my HIV status to a friend, okay? And this person's called Anna, for instance, and Smith, and it's a friend of mine. You can either state their email or phone number when disclosing. So I'm just going to use the email address instead. And there's a bit of a text over here that's provided. Know why you want to tell them. Why do you want? What do you want from them? Anticipate their reaction, and so on. When you can then say proceed, and when you're disclosing your status, you're providing some of the information about your medication, your non-HIV medication, and so on. Your current status. You clearly say it shows that you're not very happy. And there's a text over here that it could be edited. So it says, I want to disclose to you, Anna, that I, Erdal, have just been diagnosed with HIV, and so on. So this text could be edited. And if we tap on disclose, so it says disclosed successfully. So an email is sent, just like the alert to clinician. So if there we are, disclosure of HIV status. And there's a bit of a text here. And if you tap on view report, just like what you've shared with your clinician, okay, you can do exactly the same thing with whom you're disclosing your HIV status to. So there's the high level information here, and that the patient report. So some of these I would have extracted, something around your lab results, your general mood, about happiness, and so on and so forth. Okay, so that's the and finally, before I want to show the connection. How does this connection between the patient and a healthcare professional works, and also the patient and a buddy, because you're not just able to establish connection and share your data reports, okay, through with a clinician, but you can also do the same thing with a friend, a family member, and so on. Let's start with a connection with your healthcare professional. Now, if your healthcare professional, this could be a community worker, your clinician, if they haven't downloaded the app, because they need to download the app, install the app, and provide their organization details, what you can do is, if you tap on this plus sign, you can invite them to download either by stating their email or phone number. So a message or an email will be sent for them, instructing them to download the app, install it, and make sure their organization details are provided. Now, whereas if they have downloaded the app and they're in the system, we'll be able to find them within our database by simply, if they can state their country, for instance. Let's say this particular patient is in Mozambique, and it's a Nampula province, okay, and it's in this particular city, Angosh, and I received my treatment at Angosh Hospital here. So if I tap on find, here I are, that's my clinician here. If I tap on my clinician, I can then tap connect, connection successful. So what I've just done is an invitation is sent to my clinician for connection. It says, okay. If I can now, I'm going to log out as a patient and then log back in as a clinician just to kind of demonstrate how this connection works. So I'm a clinician and I'm just going to, I've registered using my email. That's my email address. There we are. I'm now within the clinician section of the app. So this is what it looks like. What a clinician or a healthcare professional could do is they can see their list of patients here. This could be tens or hundreds, okay, where you can search for your patient, by just simply typing their name, surname, or you can invite a patient if they haven't downloaded the app. So you can send a invitation by simply using a phone or an email, or if you provide the list of all of your patients, this is something we can also do via the dashboard. So instead of inviting your patients one by one, we can send out an email or a text message in bulk. So if I can see, like, there's a connection request here. I've just made a connection request. This was me earlier on, where I've entered my clinician, the country, the state, the city, and so on and so forth. I've requested an invitation, and over here, once they tap in, the clinician could either add the patient to the list or reject. Okay, and if I can go back to my patient list, and there we are. This is the patient that's been added to the list, and this is what they see at the top. So at the top, there is some warnings, some critical messages at the top. So you've got this patient is depressed, has suicidal tendency, and their adherence is below 50. So something that needs to be looked at immediately. There's also some reminder information, something around their medication, the medications that they're on, the appointments, and so on. So all of that is listed here, and they can have a look at just like the reporting section. What I demonstrated during the reports for in the patient list, the clinician has access to identical information, but more. So, you know, you've got the patient adherence to here, the viral load, cognitive problems, risk calculation, physical symptoms. We've also added depression and patient satisfaction about the service. So there we are. Look, their mood is kind of, it's fluctuating over time. But for the past few months, you know, they're depressed, you know, often and very often. So I think that's something that needs to be looked at immediately. Loss of interest in life. So that's the suicidal tendency. There we are, suicidal tendency at times. So, in addition to this, treatment preferences here. So we provide, so based on this, for this particular patient, you know, emotional quality of life. That's something they want to work on. You know, HIV infection, not obvious. Flexibility in dosage, probably that could be the reason why they're unable to adhere to their medication. 3 tablets per day is a bit too much. So some of the preferences is provided here. Okay, so that's the demonstration in terms of how this connection between a patient and a clinician works. I think it's fairly timely at a time when, you know, because of COVID, patients do miss out on their appointments. So, you know, the app over here could act as a way of, you know, making sure this uninterrupted care is provided. I mean, during the workshops we had with 2 in Nigeria and 1 in Kenya, we had several users where they also expressed that visibility of going into a HIV clinic for a routine checkup was highly stigmatizing, and so the app could now act as an intervention, possibility to reduce stigma. And also not just on the stigma on the prevention and treatment of HIV, but also reduce some of the routine clinics, because they can continuously monitor their blood results and maintain contact through the app. Because by reducing some of these routine clinic visits, it also saves traveling time and waiting time, which has the potential for savings, because we know traveling could be fairly costly in many parts of Africa, for instance, because even hopping on a coach or a bus to get to your HIV clinic can be costly. So several users expressed how useful the app can be in that sense. I've just demonstrated the clinician connection, the buddy connection. So how the user connects with a family member or a friend. It's exactly the same thing. Okay, but as an additional feature, there are some reminders. So the buddy, so the friend or the family member, will also receive their medication reminders in case they forget to their medication. A friend or the family member could remind them to take their medication. So that's an additional feature provided when buddy connection is established. So that kind of summarizes a demonstration of the app. Now, there are other features in the pipeline. Pharmacy, for instance, medical laboratory results. Okay, we're receiving your medical laboratory results, your viral load test through the app, for instance. That's just under implementation. The community pharmacy is also under implementation, where you could receive your prescription and go to your nearest your pharmacy to pick up your medication, rather than traveling all the way down to your clinic just for your prescription. So hopefully in the next coming months, these additional features will be implemented. So that completes the the demonstration for the app. I think before I move on, do we want to take some questions at this point, Andrea? Is it?
Yes, thanks, Aaron. I think we can actually mark a short break. I know that also in the chat we've been trying to answer the question, but it may just make sense to read a few of those, because I suppose that there are some who, like me, are technology literate. I may not be accessing the chat window. So yeah, those should include some questions initially addressed to Shola as well. I know you've answered them, but important just to go through a few for those who are not accessing the chat indeed. So the one question was actually how do you think that the SmartHIV tool can be used in Africa to distribute intervention, and where would such intervention be coming from? Shola, I know that you try to answer, but would you mind just re-echoing the answer for all our participants?
Absolutely. Actually, if you listen to the talk so far, we've only actually tested the app in Africa, 2 sites in Nigeria and 1 site in Kenya. So they are actually, compatible with the African population and also the systems that we have in place. And in terms of where the interventions are coming from, of course, currently, the donor organization, they have a lot of interventions targeted towards people living with HIV. And some of these interventions can, they can leverage the solution to be able to improve on the intervention or the pathways to getting the intervention to where they are needed. One of the beauty of this is that if they invest in this app, it could actually end up saving costs. For instance, one of the feedback we got from most patients is that this app is actually reducing their visits to hospital and the amount of money they have to pay to travel to hospital. So one way or the other, this is one of the ways of also, reducing the inequality in access, because most people can't go to the hospital just because of financial limitations. So I think the tool is in a very good position to be used if the opportunities or the opportunities are explored.
Thank you so much. I'll read the next question and the answer, because one attendee asked whether they could possibly have a certificate after attending this presentation, and the answer is yes. I think for those who need the attendance certificate, they should email the organization, and then they'll be issued one. Then the next one, which I think is also very important, it's actually, how did you see the application or implementation of the SmartHIV Solution app in low literacy or educated community?
Yeah, thank you very much. Like I mentioned before, we've only demonstrated and actually pilot this in Africa. So, and the way the app is built, I'm sure, we've used this traffic light system, which most people can associate with. Even in Africa, anything you see that is red is not good. It's like spilling the blood. So, and when you see green, it means okay, it's okay. So we've used those kind of themes to be able to communicate. Even when people cannot read the text, at least they can see, whether something is red or green. For the case of garlic, interacting with an ARV that Aaron shared, you could see that it's really red. And I think it's a sign that, something is not good. So, yeah, we try as much as possible to do that. On the other hand, during implementation, let's assume a government, a district wants to implement this to their patients, we will also do a stakeholder assessment of the level of the patient population, and then we can easily adapt the app to that patient population, and we can scale.
Thank you so much. The next question has been addressed. It was about, is there room for family support and community? Because many people with HIV, because of many people living with HIV rely on others, and the answer is yes. Actually, that's fully addressed by the body component of the app. Yes. So then the next one is there a support department or help desk center at a BA Smart app, and that provides further support to user on how to navigate the app? I think Shola and Aaron, you may want to comment on that also as well.
Yes, we've got a support at bsmartlytics.com, but beyond that, you could actually contact us to have you trained, because I mean, you need to get the basic training. The support is actually when you have technical difficulties. But in terms of training, we can organize a one-on-one training with you guys. If you want, maybe at a service or center level, if you want to identify somebody which can be a trainer, we can train the trainer, and then the trainer can be able to, to train other people and provide some support at local level, and things that the person cannot resolve can then be escalated to our support group.
Thank you so much. Then another question, do you have plan to cascade this program or app to be implemented in different health facilities in different corners of Africa and the world?
Yes, absolutely. And I think I would actually want Esther to comment on this because she's on the field, and I think she will have a bit of more information about how this can fit into her daily job, for instance. So, but yes, we can, yeah.
Well, I think if that was part of the talk of Esther on the panel, that she may have to postpone it. But Esther, if it's not overlapping with your communication, you can add to what Shola just said.
Yeah, sure. No, yeah. I can go ahead. No, I think on all aspects that have been described about the usability of the app would definitely benefit patients out in the field, starting from the patients taking more ownership of their own health. Because I think that's one thing that has really been lagging behind in the care that we provide to patients. It's all very much clinician or caregiver-led rather than led by the patient themselves. So if they can feel more ownership of saying, I can do this for myself, I can check this for myself and see how I'm doing, and don't have to rely on what my caregiver is telling me to do all the time, I think that is really great. On the caregiver side as well, especially in this environment where there is COVID and other competing priorities and social distancing and trying to reduce time spent at the health facilities, it does provide an opportunity for the clinician to stay in touch with their patient without physically having to be with the patient in the same room. And for planning as well, it sounds like it's a great app in terms of making decisions, in terms of whether we have enough resources, how many of our patients are on what regimen, what needs do we have, or our patients depressed? Do we need to bring in more psychosocial support and so on? And so I think it's really, really a great app, and I'm really excited to hear some of the things that the app can do, because it sounds like it's really revolutionary. So thank you.
Okay, thank you. Then another question, can the recording be shared, please?
Yes, absolutely. The thing is that depending on how we share it, it might be too heavy for emails, but we would upload it on YouTube and share the link so that everybody can have access to it.
Okay, then I think another question, maybe the last one for this round, is the question is stated as follows. Is registration in the app being done in language other than English? I think this device will be more accessible for people who know how to write and master technology. I don't want to say it's not worth it, but I want to say that it is a challenge.
Yeah, I mean, this is not, we love something that is challenging, and we can easily translate the app. I mean, when I was talking about, rolling this out in a particular service or district and talking about a stakeholder assessment, It's all within the stakeholders assessment to be sure what type of patient population do they have. If they are not that literate, we can seamlessly translate the app into any language. You know, we just need, you know, we just need a bit of time to be able to get that, you know, deployed for specifics to that patient population. And then just to come back to, you know, to that person, that was a very good question. If you look at the most difficult to treat patient population in HIV, these are young people who are techy, they are tech savvy. So if you look at people who are really taking treatment and services serious, these are mothers who can go any length to support their family. And if let's assume that is even the population we want to roll this technology into, we will have done a lot by empowering those populations. It doesn't mean that the app cannot be used by other people, because it's scalable, it's adaptable, we can roll it out in any language. But we always tend to think that, oh, people are not techy. But the younger population, which are mostly the new infections coming out of Africa, is mainly in younger population, right? And these are people who are on social media using technology on a day-to-day basis. So we shouldn't be looking at barriers to, you know, hurdles that are not really there. So if we really want to do something differently, we need to leverage solutions, and there's a lot more advantage and impact that we can make than not doing anything at all about it. So that's just the point I want to make.
Thank you so much. I think I'll read the last question with the answer directly. Will the app replace the standard patient-clinician interaction through clinic visit? And the answer is no. It will try to optimize such interaction. So I think, Aaron, over to you for the last part of your demonstration.
Yep, thank you for that, Andre. There'll be plenty of opportunities at the end for questions and a discussion. But we have a lot more to cover, because this is not just an app. It's well beyond an app. And the app is a very important feature of SmartHIV Solution, because as Shola just mentioned about empowering patients, but it's beyond that. And that's what's really important. If you just remember from the slides, Shola mentioned supporting all stakeholders in the fight against HIV/AIDS here, because we need to make sure that the technology does not just empower and support patients, but it also supports clinicians, supports managers, policymakers, ministers of health, and so on and so forth. And so what we have is the web-based platform over here, how it kind of interacts with the app, for instance, how it communicates with your electronic medical record system, and so on. So that's what I'm going to demonstrate over here. So I'm going to do a quick demonstration of SmartHIV Clinician and SmartHIV Manager here, and some of the other modules that we have within SmartHIV Solution. So let's start with the clinician here. And if I can just remind you what the clinician is, the idea is to be able to support clinicians, not replace, support, okay, to provide the best possible treatment outcomes, okay, with all disease-related complexities for their patients, because, you know, HIV patients are aging with various comorbidities, and the intention of this technology is to help with the optimal ART selection, but taking into consideration things like, you know, co-medications. Let's say, for instance, for a particular patient consulting their clinician, okay, they are adult, male, let's assume they're non-white, okay, and it's a newly diagnosed patient, naive. Now, if they're TX experienced, there's other selection that comes up, you know, whether if there's any mutations, for instance, how long they've been on treatment, whether if the intention is to switch, and so on and so forth. But let's keep it simple. This is a naive patient, okay, and I want to see whether if they have any drug interaction. Let's assume that this patient has type 2 diabetes, for instance, so they're using an anti-diabetics medication, and they're also using illicit drug, Okay, so if I can just, sorry, I can scroll down to illicit drugs that they're on. Okay, and I need to select the specific anti-diabetic medication and the illicit drug the patient is on. And let's assume that this patient is on metformin. If I can scroll down, there we are, it's here. So these are all the anti-diabetics medications listed. And if I can scroll down, and let's say the patient is using cannabis. Okay, just it's very similar to the app that I demonstrated earlier on. If I click on clinical outcomes, what this does is just to kind of just a bit of give a background about how this is working. It's made up of all the clinical trials that's been conducted since 2015. Okay, we have the all relevant data for that. Okay, that includes the suppression information, adherence related information, and so on. There's huge amounts of data that's collected based on all the clinical trials conducted since 2015. So what the algorithm is doing is it's selecting the top ART, the top 5 ARTs we're recommending. So all the viral suppression provided at the end. And if there's no reliable data available related to, say, death-related information, that's not available. We won't provide any information until the data is sound. So for each of these selected ARTs, the top 5, we provide the overall suppression and the expected suppression over week 24, week 48, and so on and so forth. Okay, so for each of these ARTs, if I scroll down, there's some further information provided. What's the expected chance of drug-related adverse reaction for each of these? So DRV seems to, with a very high, was the highest, 43%. DTG plus 3TC's got the lowest expected chance of related adverse reaction, and also adherence. So in terms of the adherence, all of these ARTs are quite similar. So again, it's some additional information where a clinician could use this or in terms of prescribing their ARTs. But it gets more interesting when we kind of deep dive into drug interactions. So this is where, in fact, our app is communicating with SmartHIV Clinician. Okay, because as I've shown the drug interaction part within the medication section of the app. So these are all the patient attributes that we've selected. And again, the top 5 ARTs, and there we are. These 5 ARTs, the recommended 5 ARTs. Okay, DRV, for instance, and EVG is likely to interact with cannabis, but it's highly likely, for instance, with the anti-diabetic medication metformin. So again, it's supporting the clinician to select the best possible treatment. So the idea is what we're doing is we're trying to tailor the ART, okay, for individual patients' concurrent medication, and also serious adverse events here. It's just taking some time for it to load. So if I can scroll down. So what we had in the clinical outcomes was all drug-related adverse events, but now we're looking at the serious adverse events for, again, each of those selected ARTs. So clearly DTG plus FTC-TDF has got the highest, almost 13% on average, okay? Whereas this one over here, for instance, EVG, has got the lowest, 2.95%. So it's all about balancing here. Balancing in terms of the serious adverse events, the drug-drug interaction before the ART is prescribed. And okay, and as I said earlier on, we're trying to make sure that the clinician, SmartHIV clinician here, communicates with the app in terms of providing medication-related information. So that's the SmartHIV clinician. Now we have the SmartHIV manager, okay, and as Shola mentioned earlier on, so the SmartHIV Manager is a web-based interactive planning platform, okay? And this is for the management of HIV services. So the idea is to support managers, public health programs, policymakers at local, regional, and national level. And the way how it works is it mimics a HIV service in a virtual environment. So what it does is it captures all of the individual patient's movement from, say, from initial diagnosis to monitoring and ART treatment. So it includes all of the resources consumed by patients, so such as the doctors, nurses' time, diagnostics, all the counseling sessions, and so on and so forth. Okay, and it basically simulates reality, what happens within a HIV service. Okay, and if we're able to capture this level of detail, we could potentially test the impact of many decision scenarios. So to compare the current practice against any possible changes. So I want to show an example, demonstrate an example, what we did for City of Kigali in Rwanda. Okay, so based on the National Strategic Planning frameworks or reports of City of Kigali, the annual prevalence of HIV within City of Kigali is around just over 6%, 6.3%. And according to the National Strategic Plan, over the next 5 years, the objective is to reduce down this to a national level of 3%. So they've outlined a fair number of frameworks, and one of them is prevention. So prevention is an important way of it's a very effective way of reducing the infection rate. Within the report, they've outlined what needs to be done, but there's nothing about the impact of that intervention over the next 12 months, 3 years, 5 years, 10 years. So hundreds of millions of dollars will be invested over the next 5-year period, but there's no analysis, nothing about the impact of that prevention, okay, on the existing patient, the impact on the service, the impact on budgeting, the impact on the city, and so on. So I'm going to demonstrate, okay, as an example here. Now, the SmartHIV Manager is designed and developed for all HIV services around the world. So you can start by selecting your country, okay? So whichever country. So I'm going to stick with Rwanda here. And what it's going to do is any country that you select, it automatically updates the data, the input parameters, because a HIV service in Rwanda is not the same as Sierra Leone, or a service in Sierra Leone is not the same as the UK, Nigeria. So all of the input parameters at the back end, they need to be updated. And the information is updated even to a level of suppression. For instance, the average suppression is different between countries. The costing is different between countries. The amount of time a doctor spends per patient is different, or a nurse. The number of times a patient is seen in a given year is different between countries. So all of these parameters are updated. So let's start. We've selected the country, okay? There's some costing information. So in Rwanda, the first line ART costs around $97 per year per patient. Laboratory costs $27 per year per patient, and so on. So the PrEP in this case costs $347 per year per patient. The beauty of SmartHIV Manager is you are always comparing it against an intervention. I mean, it's good, it's great to know, the status quo, okay, as is, but what impact is an intervention going to have X number of years down the line? So you want to be able to compare against an intervention, okay? So that's the costing side. Now, I want to run my simulation, okay, over the next 5 years. That's my prediction, my forecasting period. In City of Kigali, that's about 46,000 existing patients. They have about, I think, just over 1,600 new cases per year. That's their annual incidence rate. And what I'm going to test is, I'm testing against the scenario. What if I increase from 1,000 people offered PrEP, so those at risk, from 1,000 to 6,500 per year? And I want to investigate, examine, in terms of the impact of this intervention. over the next 5 years. So that's what we're going to be running the simulation for. So the increased use of PEP over the next 5 years. Now, there's more input parameters here. So, in the city of Kigali, the vast majority of the patients are female, they're adult female, compared to male, 62-38. This is the age breakdown, so 60% adults, 25%, 60% of adults and 25% adolescents, and so on. And obviously, these percentages, we can easily change them according to the setting, whether if it's local, regional, or a national setting, against the scenario. Sorry, I need to go back. So the prevention that we're testing is 75% PrEP against 25% PEP. I'm not changing the scenario because I only want to test the increase from 1,000 to 6,500 over the next 5 years. Things like ART classes prescribed, they vary between countries. The treatment times, this is a very, very important metric because we are capturing reality. A service runs from 8 a.m. to 6 p.m. Monday to Friday or Saturday. All of that is captured. How long does it take to treat a naive patient for the first time, for instance? 30 minutes. Okay, what if that comes down to 25 minutes? I can test that scenario. Counseling sessions, okay? Monitoring, when they come for the first time, it's around 45 minutes, okay? As for a TX experience, it's about 25 minutes. That's the time spent by doctors, okay? Monitoring visits, how many times do they come back in a year? A naive patient is 8 in a year, TX experience twice. Well, I can test in the current COVID, for instance, there's a lot of cases where patients come back once a year. That's a scenario that could be tested. What's the impact of that? But let's keep it to 2. Okay. And there's a lot of input parameters around human resources, the number of doctors, number of nurses, and so on and so forth. I can specify my human resources here. I could test for my UNAIDS, for instance. Well, if I'm a country or a service who's at present around 75, well, I can test against, well, what resources do I need in place if I'm trying to achieve the target of 90-90-90? Okay, so there is that option to run UNAIDS associated targets. So let's, yeah.
Maybe to minimize the volume of new information to be digested by participants.
Sure.
We may have to maybe to pause here.
Okay.
I hope that I think other panel members bringing their perspective could also help to help to assimilating more what we've got today. I must say it's very impressive, and it's just a glimpse of what actually this solution can offer.
Sure. Can I just very quickly run the model?
Yes, please. Indeed.
Because that finishes it. That's it. We've done that.
Yes,
We're now running the simulation. Just the last kind of 2-3 minutes, because I'm not going to go through all the results. The results are huge.
That's fine, yes. Mm-hmm.
It takes about 30 seconds or so to run. Going to run it here as well. Actually, I've just produced it here. Yeah, I can show it here very quickly. So based on this scenario, okay, we produce all the set of results. So comparing the current practice against the scenario for each of those 5 years. So if I can just tap on here, so you can see, for instance, you're in for 2022, for instance, as a result of increasing your prevention program, if you continue as it is, you'll expect it to see 1,500 new cases in that particular year, whereas in the scenario, this comes down to 785. In 2023, comes down to 537. But it kind of shows very detailed set of results, okay, on a wide range of metrics, okay, your monitorings, the counseling and adherence, okay, all the activities associated with that, okay, your human resource needs, okay. So you can see what are your requirements for doctors, your doctors, pharmacists, medical lab scientists over the next 5 years, okay, with this new intervention. It's because of this intervention, the required number of doctors and nurses, there's a bit of a reduction because of the prevention, okay? So it's always comparing your current practice against the scenario. So, for instance, your required number of doctors is around 58 in the current practice, whereas in the scenario, this comes down to 55. Okay, now, so that's just kind of provides a very detailed set of outputs in terms of your planning needs over the next 5 years. Okay, and finally, I'm just going to show prevention, Andre.
Okay.
And that's the prevention side. So if I can just quickly come down to number of averted cases, there you go. Look, you can see if you carry on as it is with only 1,000 PrEP offered per year, okay, that's the number of cases you expect to avert. Whereas if you go ahead with the 6,500 PrEP offered per year, that's the number. Say, for instance, 1,400 is expected to be averted in 2025. And if you come down, there's a lot of results about the cost effectiveness. So clearly, just very quickly, it says, look, this scenario that you're running is cost effective because you're expected to avert about 4,700 cases, okay? And it's only costing $604 per averted case, okay? And then you can then start kind of measure the impact of this intervention on your service, on your human resource requirements, even on your budgeting, okay? So there's a lot of outputs around your budgeting needs as well. And I'm not going to go through the detail. There's a lot of outputs here that's been generated for planning purposes. Okay, thank you, Andre.
Thank you so much, Aaron, for actually taking us through, I know, quickly through the extensive solution offered by Bohemian SmartHIV. I think most of the questions have been addressed already, but I'm also mindful that we've got other panel members. Maybe we're going to give each of them just about 3 to 4 minutes to bring their own perspective on, on the contribution of digital solution to HIV prevention and care. So then, in no particular order, let me start with you, Emmanuel, please, 3 to 4 minutes. Prof. Emmanuel Gemeli, the floor is yours, please, if you're with us.
Yes, thank you very much, Andre Pascal. In terms of perspective, as a public health practitioner who often have to address the challenge of being able to make decisions on how to allocate resources to be able to address a particular challenge. And here we are talking about HIV. You realize that you need some information that most of the time you don't have. Then we ended up making decisions based on assumption, a lot of assumption, and the more assumption we use to make decisions, the less effective our result might be. We all know that health disparities is really what help disease to propagate, and is also what, if we don't address, will actually not help us to be able to control the HIV epidemic and any other epidemic anyway. But how actually can we be able to address health disparities and make sure that we address the need of every single of vulnerable populations, key populations, HIV patients, and orphans and vulnerable children, adolescent girls and young women, not to repeat myself, because they are part of the vulnerable populations. How can we actually address the risk and vulnerabilities of all of these populations in a certain manner that we ended up decreasing the number of new infections? And if for those who are already infected, we actually help them to be able to access ARV and also to remain on treatment and become viral suppressed. How can we achieve that if we actually cannot be able to bring together several sources of data? Our programs are built with standard monitoring tools. What we see with those standard monitoring tools is that we collect some information, indicators, and we use them. Most of the time, we analyze performance indicators on one side. Often we don't even collect expenditures indicators, not to talk about the quality indicators to actually give us a good understanding of the quality of care that we are providing. How can we actually bring together not just the performance indicators, but also good understanding of the unmet need, being able to have a clear understanding of the target population that we need to serve, build the capacity that will actually meet that unmet need and that target, and being able to monitor that we are not having too much staff compared to those who are actually requesting for services, and can be able to adjust staffing with the need and the demand, and continuously adjust those parameters at the site level to actually be able to make our site not just performing, but also efficient on how we use resources, so that every single dollars that we spend at the site can actually make a difference. So how do we do that without having a tool that actually helps us to bring the data together? In my experience, most site managers, who are the most important people probably in the program, while they know the terrain and the need, they don't necessarily have the skills to be able to analyze data or the resources to be able to do so. So having a tool that actually bring them, help them to be able just to visualize the information that they need without having to analyze the data, without having to spend too much time on those particular very important but boring tasks. I think that's definitely can make a huge difference. So I'm listening to the presentation made by Shola and Erin. How can you not see that this is actually an innovation that can be a game changer and can definitely have the way we conceive and we implement programs by really looking at that in the business mind and being able to make sure that we are much more efficient than what we have been in the past. I hope that I have not spoken too much, Andre Pascal, and I think that's my small perspective after listening to Shola presentation and even demonstration.
Thank you so much, Emmanuel. I think it was just so interesting listening to you, bringing the public perspective with the challenges and how actually these digital solutions can help to address them. So I'm going to move from you to Esther. Esther, are you there?
Yes, I'm here.
Yes,
and
Esther,
thank
please,
you.
let's hear from your perspective. Thank you.
Yeah, no, thank you. I think I probably said a lot of my own perspective earlier on, but I really do think that thinking back to the time when, you know, they said that Africans should not be put on treatment because they don't know how to tell time, I think we've come a really, really long way, really showing the world that our patients can take medication and they can be virally suppressed. And, you know, we're moving beyond just coverage, looking more towards quality of care. And I think if there's one thing that COVID has taught us is that we need to have more better, more innovative, more different ways of doing things that are not the routine things that we were doing before, where, you know, our patients have to come in and queue up and be seen and, you know, spend lots of time waiting to be seen and so on. And so whilst it had its you know, its bad effects in terms of, you know, killing off people and so on, it did teach us that, you know, the digital world can actually move us more better towards better quality of care. So for me, this is coming just at the right time, and it ties in very, very well with more patient-centered care and having more ownership of the patient in terms of taking care of their own health. And I think it's very exciting. In terms of, you know, whether we can reach all our patients with this, of course, not everyone will have a phone, but the truth of the matter is the access to smartphones is much, much higher than people think. Even in the most remotest of places, a person might not have their own phone, but might have access to a neighbor's phone, a relative's phone, and so on. And so for me, this is really very exciting. Thank you.
Thank you so much, Esther, for such interesting perspective. Actually, clearly highlighting the fact that we're moving really beyond the simple coverage and actually embracing the quality, and which come with new challenges, and which in your view, and you really said it, that they are going to in some way be addressed, at least among other by the digital solution. So let me move from there then to Joshua. Joshua, are you there? Joshua, are you still with us?
Yes, I'm still with you.
Yes, please. Thank you so much. The floor is yours.
Thank you. Thank you so much, everyone, and thank you for joining in this discussion. My first take will be we are moving to the digital world, and we must appreciate the technological advancement because people really want to have time where we can communicate. And I would say the first thing is telephones brought easy communication in the world. And so there's a lot of advancement when it comes to communication. And that also brings us to these three apps that have been discussed. Yes, there are apps and people will want to see how to really mitigate these apps and get services very fast, because we are coming out from a way of just coming over to check our health outcomes, coming just to ask, when am I coming back for clinics, coming to just know what are some of my weights, should I check, coming to at least look at the files. So this is a point where people really want to know their status, know their health outcomes, and it means using these apps really brings out an ideology of knowing yourself better than anyone else. And I will say that people now are moving from the analog way of doing things to a more digital way. And even in countries, people are developing different digital integrated programs just to try and look at a focus on various subpopulations, including the adolescents and young people. Really, even messagings today in Kenya, people have different platforms just to give a message, to deliver messages. And so this is a good platform, this is a way out to also see management of HIV programs, management of HIV patients, then the linkage of body, the linkage of clinicians, very, very crucial. And that means it's not a must that you have to visit the facility to talk to a clinician, because sometimes people also don't want to talk to clinicians. I'm really glad I saw something about mental health. And because I do a lot of advocacy community works, so many people always want to get a psychological counselor whom they don't know. And because we do referrals to some of these hotline numbers, you realize he's very contented to speak to that person that he doesn't see, but is able to speak with him via phone just to get an advice, as opposed to somebody whom you know, whom you may always think that is going to share your messages. And that is what is called the confidentiality that really comes within these platforms. There we go. The world is going digital, but all in all, let us work to end up the inequalities. Thank you, and back to you, Andrew Pascal.
Thank you so much, Joshua. Indeed, the world is going digital and providing an opportunity to actually reduce the inequality. So with that said, let me move now to Mosele. Are you there, Mosele?
Yes, I'm still here.
Yes, please.
Me again, Andre. What I actually think about this development is it's going to make life so much easier for me as a clinician. I've mentioned on so many times that now healthcare is more about quantity than the quality. And some of the patients that default because they don't have a good support structure, because they don't have all their answers, their questions answered. And in most times I've noticed that there's patients that are on ARV treatment, but they don't really know what's going on. They don't know the difference between an EGFR that has declined. They don't know the difference between a CD4 count and a viral load. There's so much confusion. And this is the one person that must be on treatment. So with this app, it will even get the patient more involved in their treatment plan. It will assist them in understanding, because most of the people that are on ARV treatment as young people, they all have smartphones, they're all technology-wise, and there's so much paperwork that goes into the actual work of being a clinician that you sometimes miss on the important aspects, like the emotional well-being of the patient. I mean, it takes a lot of discipline to comply to treatment. So most of it is actually psychological than the actual act of taking the medication. And you know, sometimes patients want to disclose, and when they want to disclose, they have a problem of how they are going to disclose to this particular person. So I think, you know, with this app, it already has a pre-written message that puts things in such a convenient way, without me actually having to be physically there to assist the patient disclose. So it's going to save me more time. It's going to save patients a lot of waiting time. It's going to save patients a lot of traveling time. So this is it. Like this is such a great thing, and I'm glad to be part of it. It's going to make clinician life so much easier. It's going to make us managing HIV patients, because it's not just the HIV that we manage at times. It's other comorbidities. Is there diabetes? Is there cholesterol? Is there hypertension? So the more they understand how HIV influences all the other comorbidities that they might be having as well, will also assist. I mean, we also miss the illicit drug use. We miss a lot of stuff, because it's always the patient must actually remember to come, and if they don't come, we realize after a while. So if they've got this app that's going to be sending them reminders, assisting with the pill count, it actually reduces all this paperwork that we need to do as clinicians, and it will get us to focus more on the important aspects of managing HIV and other comorbidities as well. This is great, guys. I'm very excited about this. Over to you, Andre. Thank you.
Thank you so much, Mosele. I think, as you said, it's going to make the life of clinician easier. I think what is interesting listening to I don't know whether my camera is still there. To all of you, I don't know whether should I said it on purpose, but because at the start, it sort of really emphasized that the BS Smart HIV solution would actually providing solution for the needs of multi stakeholders. And I think all of you currently coming in from your own perspective as sort of providing an adequate response in showing how your needs, especially being addressed by the tool, yet you have to functioning in completely different area. I think that then brings us to the end of the short presentation by each panel member. So let me just watch the chat to see whether there are new questions we haven't addressed. Where I did stop, just hold on a second. Yes, Shola and Aaron, one question was actually the app is quite interesting, but the worry is the internet connection and literacy level of patients. How will it be handled?
Yeah, thank you very much. I'm sure I've said something about it before. So in terms of internet connection, not all the services within the app need internet connection, but services that involve sending, communications to clinicians, for instance, unless you are using the phone number and sending SMS, you really don't need internet connection. You just need mobile connection. And services around peer reminder, appointment reminder, this can work without internet connection. So that's the way the app is. So the core functionalities that patients need day to day are, you don't need internet connection for them. Not every day you want to alert your clinician. Not every day you want to contact your clinician, but maybe every day you want to see whether your appointment is coming up or whether you've taken your pill or whether you have so many pills left. So the core functionalities does not really need internet. Only the more sophisticated services need internet. And in terms of making sure that we tailor to a particular population, currently, like I said, the way it's built, we use a lot of traffic light system, which almost everybody can identify with. But when we want to deploy for a service and their patient, we do a stakeholders assessment and the demographics and the type of patient population they have. And even if it needs translating the app to another language, if it needs other functionalities that they want to add, if it needs certain functionalities they want to remove, this can be done seamlessly. We can tailor the deployment and scaling to their patient population.
Just to add to that, Shola, sorry, Andre.
Yes, Aaron.
It's a bit of a learning progress for us as well, because we've only launched SmartHIV Solution, including the app, back in July. So as we learn more, we are integrating some features. So for instance, back in July, we never had a phone number integration, but we were told that nobody uses email in Africa. So immediately we had to have the phone number integrated for ease of use. Okay. And just like we were told that offline, sometimes you run out of data. So you've got no data. And what we are just working on is, you could complete your survey, but as soon as the data is provided, it kind of syncs with the app, okay, and the solution. So that's kind of in the pipeline. We're trying to make it as easy as we can for those particularly, illiterate, for instance, rather than text, a color scheme. Okay, yeah. So it's a bit of it's the beginning. There's a lot to be done. Okay, but we are aware of these issues and we're working kind of tirelessly. Okay, but we're getting there.
Yeah, I just want to mention that I think the difference between Bohemia Smartlytics and any other organization is the fact that even when there are problems, we look for solutions. We don't throw away something just because there's a problem. We look at that problem and find solutions to it. We will be in contact with, as we get as much support as possible. We are even planning to, get into contact with certain mobile phone providers. We're ready to, get in contact with people who can help us with, charging of mobile phones with solar system. If the power that be, the decision makers, the policy makers are really interested in something, where there is a will, there is a way. And that is how we function in Bohemia Smartlytics. As long as there is a will, there will always be a workaround, there will always be a solution somewhere. So for instance, people complain about, oh, if you smartphone this, smartphone that. If the policymakers are really interested, if they talk to a mobile phone company in China, they can provide a basic Android phone for less than 15 pounds. And mind you, that cost will be recuperated from the savings, that will come along the line. So at the end of the day, we just need the will, and then the way will be there. Thank you.
Thank you. Maybe one last question, since this session is coming to an end. I mean, as interesting as it is, this solution is likely going to come at a cost, maybe to the patient and to the stakeholders. Would you mind maybe addressing that particular aspect?
Yes, definitely. There's nothing free because somebody needs to pay for it, and we would actually love to actually roll this out free for patients. However, it needs support. So it needs support so that we can sustain it for a very long time. We don't want it to be something that we roll out this year and next year it dies. And that's why we would charge a token per patient for using the app. And it's really, like I said, if the people who make money available are really interested in it, it's really nothing. In fact, if there's any philanthropy who says, I give you the money that you spent on the development, I will release this much money for maintenance over the coming years, we're ready to roll this out free for everybody. Note that the development has been funded by the co-founders of this company. No funding has come from anybody. And it can be tiring financially also. So there will be some cost, but it's really negligible. We're looking at $1 per month per patient, something like that. This is really negligible compared to the amount of money that are spent now, and you are not even getting the right result from it.
Thank you so much. Aaron, anything to add?
I just wanted to add something around the use of the app, because I just want to mention something about, we had 3 workshops, okay, 2 in Nigeria and one in Kenya, and the age range was from 18 to 60 or 62, and the education was from no formal education all the way up to university degrees. Just there's quite a lot of questions that's cropping up around education and background. Now, from that 35 users, we never had a single instance where they complained about not being able to use the app, whether if it's around completing the survey, setting up medication reminders, appointment reminders, and so on and so forth. So I think there is this, Esther quite nicely mentioned, there is this perception that if you're illiterate, if you have no formal education, you will struggle using the app. I mean, based on that sample size of 35, statistically speaking, the sample size of 35 is not a bad sample, okay? We haven't had a single instance where any user had experienced any form of difficulty. Okay, I wanted to make this very clear.
Okay, there is a last question, but it's already been answered, which is actually about the way that you do have a privacy policy, and I think that the link is provided in the chat window to the privacy policy. So we shouldn't be spending time on that. So I mean, let me just give my own summary before actually handing back to you, Aaron, for maybe for a final word. It's clear that the population of people with HIV is huge, about 38 million currently, and with the access to ART, they are living longer, and that from the survey you conducted clearly suggests that it comes with a challenge, both for the patient, for the healthcare provider, and for the many other stakeholders who take part in the prevention and care of HIV. And it's also clear that actually digital solutions are going to be part of the way forward, and I think it clearly is what you are proposing through the BA SmartHIV Solutions. And it's also very important that this is in some way addressing the need of the multiple stakeholders. On that note, I think I want to thank all of our speakers and importantly, thank our many attendees. I think at the peak there were about 50 of you. I think that's so interesting actually. This sort of exercise. So with that said, please, Aaron, I think over to you for the final word, if any.
Brilliant. Thank you very much for that, Andre. That was a nice kind of wrap around. I just wanted to finish off by saying, this is the beginning. We've only started this journey. We've been working tirelessly for over 2 years, and we still have a lot more to do. Okay, and we know some of the limitations of our SmartHIV solution, but we're getting there. Okay, and it's a bit of a learning progress. Okay, and the development is ongoing. Okay, and there's a lot to be done on our sides, but the technology that we have as it is have really sparked a lot of interest globally so far. So thank you, Andre.
Thank you so much. Shula?
Yeah, like I said, when there is a way, when there's a will, there's a way. The good thing about our company is that we don't run away from challenges. If you have ideas and you want to engage with us, just let us know. We are happy to, to engage with anybody. Our main mission and why we actually started this journey using our own money to develop this is to actually make this readily available for patients, and how, whatever form that takes, we are happy to collaborate with as many organizations as possible, as many individuals as possible. But we see that this, if this technology is leveraged, it's going to save a lot of costs, not only on the patient side, because also on the provider and also on the policymaker side. It's also going to help alleviate some of the issues around inequality, which is a buzzword nowadays. Everybody is talking about it, but nobody is doing anything about it. So that's the thing. Let's collaborate together and let's make this tool available for use. Thank you.
I think that's going to be a nice conclusion. And on that note, I also want to thank the CDC Africa for the opportunity to organize this webinar, which, as you said, is just a starting point. So, with that said, colleague, attendees, thank you so much for taking time to join this session. And I think we should now close. Thank you so much.
Thank you very much, everyone.
Thank you, everyone. Take care.
Thank you, Mosele. Thank you, Esther. Thank you, Emmanuel. Thank you, Joshua. Thank you so much.
Thank you. Bye-bye.
Take care. Bye.
Bye. See you in the next session. Not yet. Bye. Thanks. See you later.
Are you bringing us back to the room or?
Yes. If you have time, yeah, for people, as many people as possible. Bye.
Okay, I think bye for now.
Bye. Bye.